Um, just want to recap what happened this year. I think all of us giving talks, talking about medical stuff, we cannot. I started out in January talking about the first Wuhan virus patient because at that time it was only starting and we didn't know what was happening. People were getting sick a lot starting from China. Of course, there was this panic on running out of essential items, right, including toilet papers and eggs and stuff. Uh, the panic happened in Singapore, but I'm glad that's all over. Every year in June, July, we will run out of masks because of the haze. Guess what? There's no haze this year, but still, all of us are wearing masks because of the pandemic. Our life has changed, and I don't know how many of you that know, but Philips definitely is part of this um, endeavor to counter what COVID-19 is done. Philips is in healthcare. We know them as making our vacuum cleaners, our irons, and our domestic electric appliances. But they also have a huge healthcare branch that actually takes care of ventilators. All right, a lot of COVID-19 patients have difficulty breathing. They have ventilators, they have monitors, and of course, they have the scanners like MRI and CT scan, which contribute to the fight for COVID-19. And really, today, what we're going to talk about is a condition that actually Philips has also contributed to cure and treat the sleep problems that we have. So, what is sleep? Now, this is showing you. Um, this is what you read in textbooks. It's a recurring state, reduced awareness. There's interaction with external environment. There's reduced muscular mobility. There's partial or complete cessation of volunteer behavior. All right. So basically, all of us sleep every night. All right. This is something that all of us know. But why do we really need to sleep? All right. So the idea about sleep is humans or animals, all of us sleep. But for a long time, actually, we never knew why we need to sleep. All right. But we know that sleep is an essential function. It allows the body and mind to recharge, feel refreshed and alert when waking up in the morning. Just like how we charge our handphones every day. All right. You go to sleep at 30% drain of your battery, and you wake up in the morning, you expect your phone to be 100% charged. All right. And that's what we expect when we have a good night's sleep. All right. And a healthy sleep helps the body to remain healthy and stave off diseases. So, what happens? So, sometimes understanding the sleep itself is not enough. You need to know what happens to you when you don't get good sleep. All right. Without enough sleep, the brain cannot function properly. It does impair your ability to concentrate, to think clearly, to process memories, pretty much affecting all aspects of our daily activities and living. And there are certain signs and symptoms of sleep, poor sleep, or sleep deprivation, or poor quality sleep, or not having enough sleep. All right. And these are numbered 1 to 7, the most frequent ones. All right. Frequent yawning. So if you find yourself or your loved ones or someone around you yawning all the time or at inappropriate times, all right, that's one of the signs. Excess sleepiness. Well, when you're supposed to be awake at work, you're supposed to be busy at work and you're sleeping on your desk, that's a problem. If you're supposed to be studying and you're sleeping during lesson time, that's a problem. And definitely no sleeping when you're driving. All right. And that happens to a couple of my patients who actually got into accident. Um, Irritable and depressed mood, definitely. All right. If you find yourself a little bit moody, um, very small little things, and then it sets off your anger and things like that, or you feel very depressed, that can also be due to the signs of symptoms of poor sleep quality. You can have increased anxiety, and people with deprived sleep or not sleeping enough can have twice uh, the chance of getting any psychiatric issues or mental illness compared to the normal population. Reduced focus, all right, very much you see, yes, inability to concentrate in children, a lot of times just not sleeping enough may tip them to behave like ADHD kids, all right, in not being able to focus, not being able to concentrate, not being able to sit still a lot, all right, so it does affect adults and children. Next one, weight gain. All right, you don't sleep enough. it may lead to weight gain and stuff. And of course, in order to counter all this excessive sleepiness and stuff, what do people do? You find yourself drinking coffee, coffee after coffee after coffee. All right, and that's definitely a sign of not having a good night's sleep. So a lot of patients may not recognize a sleep problem, but I want to draw the attention that a lot of people with nose problem have sleeping problem or have breathing problems at night, and we can recognize them. All right, or you walk on the street, you can see people like that, having sniffing a mint tube to clear up their noses. So people with runny nose, constant blocked nose, are able to not able to breathe very well at night, and they start having problem with sleeping at night. And people with nose problem can present as sinus problem, asthmatics, middle ear infection, blocked ears, and of course they have snoring issues. And these are very important signs and symptoms of people having possible sleep deprivation, sleep affected at night, causing that problem. So now we are going to more of the definition of what we talk about sleep. All right. So you we know the consequences of not sleeping well. Well, there are major two types of sleep, what we call the non-rapid eye movement, non-REM, which have three substages of N1, N2, and N3. And then you have the rapid eye movement, which is the final stage of sleep, rapid eye movement, whereby your whole body is paralyzed except your eyes are moving. All right. And we generally go through 4 to 5 cycles of sleep. We go from the non-REM to REM, and then we go back to REM again, to non-REM again. So basically, it's light sleep, deep sleep. We comes out again, light sleep, deep sleep. We go through about 5 cycles on average every night. All right. So this is what a normal sleep would look like. We don't sleep in our brain doesn't just exist at one level. So there are many common sleep issues. More than 84 types of sleep disorders according to the international classification. All right, so many things can go wrong with sleep, but pretty much divided into 6 main categories. All right, the first one is insomnia, which is inability to sleep. And then you have the sleep disordered breathing, which is the main thing that we are talking about because it's very common. There is, of course, hypersomnolence of central origin. There's circadian rhythm disorders of sleep and wakefulness, the parasomnias, and their movement disorders. But pretty much majority is going to be sleep disorders, of which Dr. David Ching will be able to give you a little bit more information on that. So insomnia is the inability or difficulty starting to sleep or maintaining the sleep every night. All right. So there are 3 main types: short-term, chronic, or other insomnia disorder. All right. So this is more the presentation and diagnosis on sleep. And then, of course, you have the sleep disorder breathing. The most common being obstructive sleep apnea. You find it in both adults and children. All right. This is due to the airway from the nose to the throat to the tongue, whereby there's obstruction to the breathing. You have central apneas, but central apneas basically means that the brain function, the brain control of the breathing is affected. All right. So it's more of a neurological problem, and it can be associated with heart failure, strokes, and renal failure patients. You can also have sleep-related hypoventilation, which means that you don't breathe deep enough, all right, because of these are associated with obesity. And also you may have sleep-related hypoxemia. That means you don't get enough oxygen. So how common is obstructive sleep apnea? Is it a 10% problem in our population? 30 or 50%? All right, Dr. Chin will be able to answer you later on. And then, is there a look for obstructive sleep apnea? All right, whether it's be cute little children like this, all right, or a young lady like this, or a child like this. All right, is there a look for obstructive sleep apnea? Again, I think Dr. Ching will be able to give you a little bit more information. I'm just here to plant some questions into your mind so that you can start thinking. Is there an obstructive sleep apnea look in our colleagues and our close family members? All right, but certainly we know sleep apnea is associated with many bad things. Again, this will be highlighted by Dr. Chin, giving you a little bit more details. So another diagnosis is hypersomnolence of central origin. All right, that means extra sleepiness due to brain issues. All right, it's called narcolepsy, typically seen in young people 10 to 20 years. And basically, what they presented with very sleepy, cataplexy, sleep paralysis, hallucination. They can just walk while walking, and then suddenly they just drop and fall asleep. All right, and this is mainly done by medical management, not a surgical issue. There are people with circadian rhythm disorders of sleep and wakefulness. All right, and what is this? Basically, we have a delayed sleep phase syndrome, whereby seen in a lot of young people where they sleep very, very late and have difficulty in waking up early in the morning. All right, so there's a change in their biological rhythm, or advanced sleep phase syndrome, whereby seen in older people, you sleep very early and wake up in the very early in the middle of the night. All right, that's why you find them having a sleep phase syndrome. And of course, all of us would have, whoever to have traveled to another time zone, experienced jet lag. That is another circadian rhythm disorders of sleep. Another big group is parasomnias, all right, of which you divide into the non-REM parasomnias as well as the REM parasomnias. So what the non-REM parasomnias, all right, this is the early part of the sleep phase. You have confusional arousals. You have people with sleepwalking, sleep terrors, all right, children waking in the middle of the night start screaming, all right. Then you have the REM parasomnias, you have the type terrors, night terrors, isolated sleep paralysis, and then you have the REM sleep behavior disorder, all right. So these are under the parasomnias. And then you have movement disorders, all right. Certain abnormal movements in the middle of the night can disturb the sleep, can wake you up, all right. And this is due to most common one we see is restless leg syndrome, whereby you have abnormal sensation in the calf muscle. You have difficulty in initiating and maintaining deep sleep. You have abnormal sensation getting aggravated at rest in the evening, and massaging the calf or moving the legs may provide relief. Right? Again, this one requires medical treatment um, to improve the sleep quality. So, how do you diagnose sleep disorders? All right. First of all, you need to see a doctor if you suspect you to have this, and we'll do a thorough history taking. We'll examine to make sure that there are no your nose passages or your throat passages are clear, whether there's any swelling, there's any growth or any abnormality that may contribute to the blockage. And very commonly, we do see deviated septum, we see huge tonsils, huge adenoids, or even the tongue being too big causing the problem. All right. And then the various tests, which includes sleep study, which can be done in the hospital or at home. And this again, further information will be given by Dr. Chin in the third lecture. All right, just to give you a quick peek, a sleep study looks something like this. Not very scary, perfectly comfortable. All our patients are able to sleep very well. And I'm sure Dr. Chin will tell you a little bit more on that. Okay, and with that, I thank you very much for your kind attention.
So obstructive sleep apnea, the three words, big words, most people think about snoring when they think about obstructive sleep apnea. But what it means is that it happens during sleep. Apnea means that you're not breathing. So it could either be completely not breathing, that's called an apnea, or we have another term for the decreased airflow and decreased breathing, that's hypopnea. So, and the reason for, in obstructive sleep apnea, the reason for not being able to breathe during sleep is because somewhere in the upper airway, the airway is being blocked. And Dr. Leong already alluded to this early on. When we sleep, our body is relaxed, and especially in the REM part of sleep, the body is paralyzed as well. So, without the muscle tone that we have as we are now when we're all awake, the structures of the throat, which are muscular, tend to be lax. And if it is narrow, it can block the airway or make it narrower. So we are able, with the sleep studies that Dr. Leong shared with you and showed some pictures, to measure a lot of the parameters that are important for living. For example, airflow, oxygen, the effort of breathing, and other things that are important to understanding sleep. And in the most detailed sleep studies, we actually also measure the heart ECG and also the the brain waves to tell which sleep state person is. So a sleep study essentially has a lot. You can still sleep comfortably, but there are a lot of little wires attached to monitor all that is happening while we sleep. So why is OSA important? It's not just about snoring. Most of the time when patients come to see us, it's because either parents are worried about their children snoring, or patients come to tell us that they feel sleepy even though they think they've slept for as long enough. But most often it's when wives come to complain about their husband's snoring and disturbing their sleep. But if you look at beyond all those things, all the cosmetic things I may say, OSA is actually associated with many, many conditions that are so common in our society now: hypertension, high blood pressure, heart disease, stroke, heart failure. And if you look at the prevalence of obstructive sleep apnea in all these conditions, in patients diagnosed with all these conditions, it is far higher than in general population. So obstructive sleep apnea is a danger sign that someone is at risk for developing all these conditions. So we talk about just death. So in patients who had either stroke or ischemic heart disease, the chance of them having obstructive sleep apnea is much higher. There's much greater risk for that. And we can see these sorts of graphs we use a lot in medical research to combine the results from many different studies. So if you're at this level 1, then there is no difference between one group or another. But you can see the risk of having obstructive sleep apnea is increased in patients that die of these conditions. In sudden cardiac death, we often hear of somebody dying in their sleep. Why does that happen? Why do they have this? And obviously, they die from cardiac arrest. But if you look at the risk level of these people having obstructive sleep apnea compared with those that do not have, there's a much higher chance of them having OSA. And so why does that happen? There are many, many studies now that show that obstructive sleep apnea is associated with arrhythmias of the heart. So when the heart rhythm is not going at its normal rate, if you can see a normal ECG, it can go into a very dysfunctional rhythm that cannot supply the blood and oxygen that's required for the body. Now, again, the same sort of plot where you can see that the risk of having OSA is higher when you look at patients who have stroke or ischemic heart disease. That's when they have blocked arteries into the heart. One of the earliest signs of sleep apnea, in my opinion, is high blood pressure. It happens long before patients actually get the heart disease and the strokes. This happens maybe 10, 20 years before. And so in the old days, we used to have this term, and we still use it, essential hypertension, which means that we didn't know what the cause of it was. The patients didn't have a hormone problem, didn't have a kidney problem. And we just assumed that, as you get older, maybe from thickening of the blood vessels, you get high blood pressure. But over the last 20 years, the studies have shown increasingly that high blood pressure is strongly associated with patients having sleep apnea or the other way around. And so if you look at normal blood pressure, now if you measure the blood pressure during the day, you'll find that there are fluctuations. But in general, if you take an average, when you go to sleep, the blood pressure is less. And that you can understand that the body's not doing much. Everything is relaxed. The heart should not have to work so hard. But for reasons that I might be able to shed, when we have obstructive sleep apnea and the body is struggling to breathe, the heart actually has to work a lot harder. And that contributes over time towards the vessels getting more used to a high blood pressure state. So today, we are not going to talk about so much about the treatment of obstructive sleep apnea. It's a very complex topic, and as Dr. Leong said, you actually need to be diagnosed, and you need to see a doctor to actually discuss in each patient's particular case what's the best option for treatment. But just to show, one of the treatments is CPAP, where we bypass the obstruction in the airway by having a machine that blows air into the airway. And there are many studies that show that CPAP does improve, for example, high blood pressure and many of the other conditions that I talked about. So beyond heart disease, high blood pressure, stroke, and we all know that these conditions are strongly related, high blood pressure and stroke. And if you look at, it works both ways. Patients who have obstructive sleep apnea have an increased risk of having stroke. And actually, once you have a stroke, your obstructive sleep apnea gets even worse because there are problems with the nerves and the control of muscle tone in the throat. So if we do a full sleep study, we do collect a lot of data, and there are many, many graphs. We can see in this case how, if you look at the airflow, normal breathing is occurring here, and in between, there's no airflow. And you can see that the oxygen level drops as a consequence of that. But the whole sleep study tells us much more than that. It tells us what sleep state we're in by looking at the eye, the electrical signals from the eye and the brain, and also from the heart as well. And there are many, many other monitors. So it's a very complex study to comprehensively assess what's happening during sleep. Now, going beyond the obvious high blood pressure, high blood heart disease, and risk of strokes, the more recent studies are showing that even diabetes and the control of glucose is highly correlated with obstructive sleep apnea. So if you look at this, AHI is the way we measure in a simple way how severe someone's obstructive sleep apnea is. I will come to that in a moment. Basically, A means the number of his apneas, number of times that a person there's no airflow at all for at least 10 seconds. Hypopnea is when the airflow is decreased or oxygen is decreased. And then index means we take the total number over the whole sleep time and divide it by the number of hours. So this index is the number of times this is happening per hour. So less than 5 is considered normal. And we divide it into mild, moderate, and severe depending on how high the AHI is. And so you can see that as the AHI increases, the glucose level, surrogate measure of diabetes, also gets worse. So we know, in summary, that obstructive sleep apnea has a lot of downstream health consequences for us. So how prevalent is it? How common is it? And unfortunately, in our society, is with our sedentary lifestyle and as our weight, we become heavier and fatter. The prevalence of obstructive sleep apnea is increasing. We all know that it's usually women complaining about men who are snoring. So obviously, it's more common in men, and it's estimated that almost 50% have at least mild sleep apnea, and maybe up to a quarter of women as well. And these risks increase when you look at other risk factors. If a patient has high blood pressure, diabetes, metabolic syndrome, the chance of finding OSA is even higher. What about children? Especially amongst children who are obese, but they don't have any other conditions, we do find that the risk of being able to diagnose obstructive sleep apnea is quite high, between 20 to 40%. So the cardiologists now are becoming much more vigilant in looking out for obstructive sleep apnea than they were in the past, because as I mentioned earlier, a lot of patients see them for heart disease, for high blood pressure that can't be controlled well. And even this study was 2015, just 5 years ago, clinic in Spain, I think, looked at this. And even in a cardiology clinic, a vast proportion of patients actually have undiagnosed obstructive sleep apnea. So this moves on to the rest of my presentation now. So now we understand that it is important what sleep apnea, obstructive sleep apnea is, how it can impact on our life negatively in the long term and even in the short term. And we know that we are not diagnosing it fast enough. And a lot of people are going through life without knowing they have sleep apnea, therefore not being able to treat. So this is one of those conditions where we need to increase awareness about the condition, and also to get screening at a population level so that we can identify patients when their sleep apnea is early and treatable and prevent all the risks and consequences of that. So when it comes to screening, in time to come, and I think we are starting to advocate this, to screen for obstructive sleep apnea when you go for a routine health check at the GP, at a health screen. And when we come across people who have all the suspicious features for OSA, then we should actually do more thorough checks to see whether they have OSA or not. One of the easy ways that's been described is this stop bang questionnaire. So you can ask questionnaires to survey what symptoms or what features patients have. Stop bang is easy to remember, because the word actually, these words actually the acronyms for the features they look for. So you can ask yourself this question as you listen to a talk. Every time if we ask, do you have this? And you say yes, you score yourself 1. So do you snore? Do you feel tired in the morning even though you've slept enough? Has someone told you that you're choking and not breathing at night? Do you have high blood pressure? Is your BMI, body mass index, greater than 35? If that means if you're very overweight. This is sad. No? If you're past 50 years old, you get 1 point free of charge. And the other thing that is easy to measure is the neck circumference, which should be, if it's more than 16 inches in a female or more than 17 inches in a male, then a higher risk. And sadly, again, just by being male, you get 1 point for free. So just by being a male over 50 years, you're already going to be on a suspicious list just by doing that. But if you add this up and you get a score of more than 8, then there is a very, very high chance that you have at least moderate sleep apnea, and therefore it is likely that this sleep apnea is going to have an impact on your future health. So what's the now with the stop bank questionnaire? So you find that if your score is greater than 3, then you're already going to be at least have mild sleep apnea. So it just, as a screening tool, it just warrants that if you get a score that is 3 or 5, that you should consider having further evaluation. So how do we evaluate then? So the purpose of evaluating is mainly to diagnose whether a patient has got sleep apnea. So we look at the history, we look at the patient to see what features they may have, and then we do objective testing, which essentially is a sleep study. So simple things. History, we've talked about that. So if someone says you're snoring or you're choking at night, you just find that you have a reasonable length of sleep, and yet you do not feel that you're well rested, having problems concentrating, memory. This is, a lot of parents are concerned about their children in school. Mood changes, sleepiness, obviously, and one way of assessing sleepiness again is you can do this test as well. So in any of these situations, if you feel like what is your chance that you probably fall asleep? So from you're never going to fall asleep, or a score of 3, if there's a high chance that you will fall asleep. So for many of us, look at this thing. So various things. Lying down to rest in the afternoon. How many of us would say they've got a fair chance of falling asleep then? You get a few points for that. Sitting quietly after lunch without drinking alcohol. There again. So if you add this up and your score is more than 10, then there's a fair chance that you're very sleepy, and this might be due to obstructive sleep apnea. So again, sometimes patients come to see doctors when they already have conditions of the heart, high blood pressure, they've got diabetes, a stroke. When you see these patients, they may not have the other features that we talked about, but it's worthwhile exploring whether they have obstructive sleep apnea, because they may have had one of these conditions, but not all. For example, hypertension, and we want to prevent the progression to these things which are far worse. Another thing, younger patients may say, well, I'm feeling sleepy, I can't keep my alertness level, and especially sleepy when driving vehicles, and that's dangerous. That poses an immediate risk to their health. So just to highlight or elaborate on that, basically the risk of having obstructive sleep apnea when is associated with the increased risk of near crashes in the car. And this is pretty much the same. So now, what features can you tell from the patient? I think most of us already intrinsically know when I see a patient, I can almost guess whether there's likely chance they have obstructive sleep apnea. One of the key things is the body mass index. And ideally we should all be less than 23. You can do the calculation yourself. Get your weight in kilograms, divide by the square of your height in meters. So someone like me is probably just at the upper limit of normal already. So there's some risk there. The other easy thing you can do is just to measure the collar. And for men, when you buy shirts, you often know that already. So that's easy to score. Another thing, Dr. Leong already talked about the nose. The nose is very, very important when we sleep, because when we sleep, we actually need to breathe through the nose. We cannot breathe through the mouth. Breathing through the mouth is not something that it just makes things worse when you sleep. It's not natural to do that. So just breathing through the mouth at night is already a sign that there might be not just nasal obstruction, but obstructive sleep apnea. But if you look in the mouth, how can we tell that the throat beyond the nose here is crowded? So if you look at some patients, you look right, open the mouth, you can see right to the back of the throat. You can see everything. You can see the whole tonsils. And that's great. That's what it should be. But as the throat gets more crowded, we see less and less, and you can go up the grades. And in the most severe grade, you can't see any of the soft tissue here. You can only see the hard palate. the tongue is taking up most of the space. Moving on also from what Dr. Leong was saying, we want to look through the nose. Now, this is a patient's right side of the nose. We want to evaluate how blocked it is. We also look from the top here, looking back down to look importantly at the junction between the nose and the throat. How much space is there here? Is it being crowded by tonsils? Is the tongue base very large? And how much space is there between the back wall of the airway? So these are things that we look for. The next thing, then we suspect that the patient is possibly got sleep apnea. Then we do a sleep study. And as I was alluding to, we have an index. An RDI is a slightly modified index where in addition to clocking the number of times the patient doesn't breathe or the breathing is not enough, we look at the times where the patient also gets woken up because their breathing is compromised. So if the index is more than 15 times an hour, imagine this 15 times an hour means every 4 minutes, one event is happening. Either the patient, you're not breathing for 10 seconds or your oxygen is dropping for 10 seconds. That's very, very often. Now, you can have sometimes if patients have very, very strongly suggestive symptoms, then we have to be even more vigilant. So anything more than 5 is actually considered to be abnormal. So this is the most high level sleep study that you can do. You can check everything from, as I mentioned before, breathing, flow rates, oxygen, movement, heart rhythm, the brain as well. So there's ENG and also eye movements to tell which state of sleep. The eye movement important to check whether you're in dream sleep, which is REM sleep, rapid eye movement sleep, or whether you're in non-REM sleep. But the number of with the growing number of patients who may have sleep apnea, the number of the capacity to do full sleep studies like that may not be possible. It does take a lot of resources and time as well. So of late, in the last 10 years, you're getting more and more portable studies. They use algorithms to try to determine which state of sleep a patient is in, but can give very, very important information as well. So there are some pros and cons of a full sleep study versus a home sleep study. A full sleep study, of course, gives you the best results, but requires a lot of resources, technicians. It's more costly, and certainly there are fewer resources to do the many tests that are required to really take care of this condition in our society. And as a screening tool, a home sleep test may be something that is more acceptable to patients because it costs less, it's more easy to administer, and it can be done in a much wider range. So, but of course, because we understand the limitations of home sleep testing, we're not going to be able to easily detect very, very mild obstructive sleep apnea. So the other thing is that we need to have patients who are relatively healthy because we don't want anything to be, when it's done at home, if something goes wrong, then there's no one to attend to that. So on the other hand, again, it's not recommended for patients who don't have symptoms because it is very unlikely that the sleep test is going to pick up an abnormality. And actually, the sleep testing should be considered as a first stage, as part of a comprehensive sleep evaluation. So it involves a physician, a doctor as well, looking at all the other features that we talked about to help to come to a conclusion whether any further testing needs to be done. So I've gone to that. So I just want to quickly talk about positive airway pressure for treatment of obstructive sleep apnea. So in broad terms, you can treat sleep apnea 3 ways. Lose a lot of weight and become very skinny, maybe one fairly successful way if it started early enough. A positive airway pressure treatment, basically you slap a mask on like this and the machine blows a bit of air and prevents the airway from blocking up. And it can be very, very successful if the patient can take it. A lot of patients do find it very difficult, and then that's when they consider surgery. And just briefly, there have been hundreds, maybe thousands of studies now showing that whatever OSA causes, the treatment for OSA, CPAP treatment can reduce those risks and makes it better. But that's not the subject of my talk today, so I will not highlight too much on that. I'm just going to go a bit more into home sleep testing because this is something that we're happy to work with Philips on, and I'm very glad that they are they're reaching out to the population to enable more people to screen for obstructive sleep apnea. So home sleep test collects a lot of the data that would be important to help diagnose sleep apnea. And when you come out with a report, it is very well presented and easy to understand. So over here, I will highlight that this is the hypnogram that summarizes what happens during the night. But essentially, you've got the demographics of a patient, age, gender, what time they went to bed, what time did the recording start, um, and then so we need to know how much a patient is sleeping in order to get that index in the end. So this is part of it. Then looking at the algorithms, the home sleep test can then characterize the number of times a patient is getting obstructive apneas. Okay, central apnea is a different thing. Central apneas occur when there's no airflow, but actually the brain is not triggering there's no breathing effort. So this is usually a problem when patients have an issue that is in the brain. For example, if they had a stroke before. So it is important to find out whether there's central apnea as well. So mixed apnea is when you've got features of both obstructive apnea or central apnea. Hypopnea I mentioned before, when the flow rate is decreased, oxygen has decreased, and then you add this together, and these are arousals. So maybe the flow rate hasn't decreased to enough to fit the criteria for this, but nevertheless, the patient is woken up from sleep, from a deep state of sleep to a shallow sleep, for example. And so you add all these things together, and then you can come up with the number of times and eventually an index. So as I said, now these are arbitrary figures. We're allowed to have up to 5 events an hour. 5 to 15 is considered mild sleep apnea, and generally the risk of developing heart disease, stroke, all that is it is increased, but not that significantly. But once you hit 15 times an hour, and you can imagine that's happening once every 2 minutes, then those risks become real. And we see patients who have AHI going 60, 70, 80. That's every single minute something is happening. So you will get these in the report and the definitions as well. And one of the other things that we highlight to patients is desaturations. Now, when you're awake, if you go to any hospital and you're with a patient, the moment the oxygen drops below 94%, you'll hear the alarm going off because it means something. Once you drop to 94, it's actually fairly serious and patients start to feel short of breath. But when we do sleep studies, you will be surprised that some patients go to the low 80s, at times even the 70s, just because they're not breathing. And this can have a great effect on the risk of stroke and heart arrhythmias as well. So this is something that is measured during a sleep study. And so if you were to summarize the whole night, you will be able to see a chart like that, the sleep stage, whether it's in the awake, REM sleep, or one of the non-REM stages of sleep, the oxygen level. So you can see here it plummets down to 70%. That it's disaster for a long period of time. And the heart rate fluctuations in the body position. And these things summarize where the airflow is limited. So